Welcome to Clinical Unfiltered, where today we're going to be getting unfiltered in the concept of blood concentrate materials, PRF, with Dr. Nathan Estrin, a really good friend of mine out of Sarasota. Tell me where you're at. Like, what are you doing? Not clinically, but I know you're like an educator in PRF. Tell me a little bit about that. Tell the audience a little bit about that.
Yeah, so my whole world just became PRF. It's not something that I did in residency, but I graduated about 4 years ago, and I've been applying it ever since in clinic every day.
This is why you have a painting of PRF behind you right
Yeah,
now.
I guess it kind of looks like PRF. Yeah. I started working with Dr. Richard Myron, who's one of the leaders in the field of PRF. I was lucky to work with him right out of residency.
Gotcha. Yeah, I hear that name a lot. Like it's synonymous with PRF. A lot of big conferences. Richard Myron I always hear is like on the list to like if someone wants a king to talk about PRF, that's him, and he comes in. And so you're pretty much like side by side with him these days.
Yeah, it's been great. He moved into facial aesthetics. So PRF continued to evolve. There's so much opportunity in PRF from a clinic, research, and education standpoint. And when he moved into aesthetics, I came into his office and took over the perio side of things. So I had to learn a lot of PRF in a hurry, straight from graduation, applying it every day in clinic, going to his courses. And I've been traveling to different offices, general and specialty offices, helping them applying the most modern techniques in PRF.
Gotcha. So you're part of his team.
Yeah, part of his
Gotcha.
research team and clinical team. It's been a lot of fun.
And you're taking over on the perio side, specifically the periodontal uses of PRF.
Specifically periodontal uses of
PRF.
PRF.
I bumped into Richard Myron the very first time I ever bumped into him. I was in a lab at Nova Southeastern University, like a small little extra room that they didn't know what to do with, that they let me put my like 3D printer in there to like play with it basically. And then I bumped into him and I was like, hey, what's your name? He was like, Richard. And I was like, what are you doing here? And I'll never forget, like, he seemed like he was very important, but I couldn't figure out what he was doing because he was a part of the perio program. But now it all makes sense. It was PRF, platelet rich fibrin, or PRP, all blood concentrate material science, and doing research with perio. Okay, there we go. Came full circle. Now I know why.
That's so funny. Yeah. And he's gotten a lot bigger since Nova and since branching out on his own.
Yeah, I've definitely seen his name grow. That's awesome. So so you know a lot about platelet rich fibrin. If there's someone completely ignorant, at least a dentist completely ignorant about platelet rich fibrin, how do you describe it to them?
And I explain it this way to patients too. Everybody has an innate ability to heal themselves. Okay. You get a cut on your hand. What happens? A blood clot forms and your body heals. Okay. So if we take a few samples.
I feel like we take for granted. That is freaking awesome.
Yeah. It's unbelievable. The human body is amazing.
Yeah.
So we're using the patient's own technology to aid in their surgical outcomes. I'll put it this way. If we draw a few samples of the patient's blood, okay, and we put in a centrifuge, what happens? All the cells separate based on molecular density. Heavy cells sink to the bottom of the tube. Lighter cells like platelets and growth factors are at the top. Okay, so we can concentrate the patient's own healing factors and put it into the surgery site. It only makes so much sense to use their body's ability to aid in our surgical.
That's exactly what's happening to my green juice right now. All the heavy cells are sinking to the bottom, and I'm just eating light gloop at the top. But no, that's exactly. So when I talk to patients about PRF, like explaining to them how I'm about to use this blood concentrate material, obviously you say that, and they're like, huh? I always am like, all right, imagine your body gets a cut, like a bunch of signals start to set off an alarm saying, we got to close and heal this thing. Imagine taking all those things and like concentrating them and then putting them back into your body for different purposes. And I'm like that. And so I even use that word. I'm like, imagine you get a cut. It goes heal, heal, heal. We're going to concentrate that and put it back into you to help the healing process. And they love it. I mean, it's an easy sell on patients.
They love it. Yeah. case acceptance is high. They love to watch it happen. Some patients are really into it. They're turning around backwards to see it. I mean, it's just been a huge game changer for me clinically.
Gotcha. So you have the PRF, like the centrifuge in the room?
I have the centrifuge in the room.
I
Yeah.
bet you guys have a centrifuge in every room.
Yeah.
Yeah.
At
Okay.
the
Gotcha.
at the office that I work with Dr. Meyer and I, we have 2 centrifuges in the 2 rooms we operate in.
Gotcha. Okay. So I have the way we have it set up because I have about like 4 operatories in my perio office. We have 2 centrifuges actually. One that we actually got that is like the Richard Myron recommended one when we took the course like way back when. And then an older one, but we use the newer one. And we have it in a distant room. So from a practice management standpoint, we kind of have our assistants knowing like when it's going, like when it's spinning, and then when to go into the room and essentially centrifuge and bring it back in. Now, granted, I have 2 assistants at hand all times, so like they know how to operate the PRF machine. It's a centrifuge essentially. That's the main thing they're using, and when and how to handle the blood concentrate materials. So I wanted you at this point to kind of take us like A to Z, how you go from drawing the blood and managing the blood to create, let's say, platelet rich fibrin.
So I used to do my own sticks for my first 6 months in practice. Now I don't. It's best to have your assistant do it because it saves time. And actually, in a clinical flow, it works a lot better because if you're running behind, the assistant can bring the patient back to a different room, start drawing their blood. Patient's getting treatment, and it's not on doctor time, it's on assistant time. And the assistant can start going through the protocols, explaining to the patient, patient's happy, you've bought yourself a little bit more time. So, if you have enough rooms, it really enhances the clinical flow because it breaks up the procedures a little bit more.
I haven't stuck a patient in 10, I don't know how many years I've been out of school now, but a long time. I've been using PRF the whole time I've been out of school. And my main reasoning, yes, it saves time for sure. You're right. My main reasoning is I don't want to be the guy that fumbles the stick and then them expect me to be the guy that does the surgery well afterwards.
They've
Like you
lost
can't even get
confidence
my
in you
blood.
already. Yeah,
Right,
the surgery
right.
hasn't
I
been
lose
yeah.
confidence,
Yeah,
like I'm on the ropes already. Like, man, I suck.
I know.
I don't want to do your implant anymore. I just know I suck today.
I'll
I'd
give
rather my
it
assistant
I'll
do it.
give it one attempt. If it assisted
Oh,
misses,
okay. So
I'll
you're
try
ready for the
once
B-man?
because then you can look like a hero if you get it, but
Yeah. Oh,
otherwise
okay.
that's it. And
Pat yourself
my
on the back.
assistants have gotten so good at it because that's all, they do it every day that now
Oh,
I don't
yeah.
even need to go in the room, nothing. So
Yeah.
it's great.
Agreed. That's the best way I think to manage is delegate it. Get one person who's really good at it, or find an assistant who I think maybe worked at an oral surgery office who got a lot of practices sticking. That's how we found ours.
What some practices do is they'll hire phlebotomists already and convert that
Okay.
phlebotomist to a dental assistant or
Oh,
orals,
gotcha. Okay.
and I think that the pay level is about the same for a phlebotomist versus dental assistant.
Okay.
You
Gotcha.
can train them on the
Gotcha.
dentistry because you know the dentistry.
That's right. That's right. Yeah, and I'm sure like that. I mean, and also that's interesting here is like you don't have to have like everyone phlebotomy trained either. You could have like a couple phlebotomy trained assistants. Like in my office, I'd say there's a couple that aren't phlebotomy trained, but we have enough where we can circulate them to get the blood. Like we know when they are needed and we schedule around that as well. Okay, so they've gotten the blood. It has gone into a test tube or a little tube. Specifically a tube. You using glass, you using plastic
I
tubes?
use both plastic,
Okay.
glass. The plastic, which are usually blue top tubes, they produce liquid PRF. So the PRF will stay in liquid form. A glass tube will stay in solid form, and that's due to the hydrophilicity of the materials. So glass tubes are more hydrophilic, water loving, platelets will stick to the walls, and the clotting cascade will get started, and you've got this nice solid clot that you can use in your
Gotcha.
liquid tubes, plastic, hydrophobic, the platelets don't stick to the walls. So you bought yourself time. It's going to stay liquid for about 2 hours. So you can use it as an injectable. You can mix it with whatever biomaterial you want. And it supports a little bit of flexibility to your procedures.
Oh, interesting. Okay, so I didn't realize that. So gotcha. Glass tubes are gonna get like a thicker material, like actually feel like a PRF that is got some consistency or something to it. Whereas the plastics are going to be more flowable. You got some time. You got some setting time
Yeah, yeah.
to
Got
work with
yourself
it.
some time.
I did not know that. So I guess I mean I'm jumping the gun a little bit, but sticky bone, is it going to be a little bit more attuned to maybe a blue? And I know there's PRP to play there too as well. The plasma.
PRP is really well, we'll jump into PRP. PRP is outdated. Okay, 1998 it came out. So when you see those signs, dermatology office, we use PRP.
Guys, this is shocking news to me. I am flabbergasted right now. Wait a sec. Okay, yeah.
So PRP was a different centrifugation protocol. They use anticoagulants in the tube so that it would stay liquid form and it would buy you time.
Yeah, I remember seeing those as like a yellow tube
Right.
that had like a little latent fluid, I guess the anticoagulants in the base.
In the dual centrifugation method that took longer. It wasn't really as popular because it was difficult to use and the results weren't as great. Um, if all wound healing starts from the blood clot, then we want the blood to clot. We just want the cells to separate before they do. So we get that supraphysiological clot, that higher concentration clot. So any tube with anticoagulants isn't going to be as efficient or as potent as a clean, sterile tube without any additives. And that's the second evolution of platelet concentrates, PRF. So
Gotcha.
PRP, to me, it just doesn't exist anymore. It's outdated technology. I would
I didn't
agree with
realize
you.
that. PRP came first, then PRF.
PRP came
I didn't even know
first,
that.
and
For some reason in my head, I was like, they both came together.
because
Like,
you hear about them
old
both
twin
together,
brothers.
and there's people that still market for PRP very heavily.
Gotcha. I mean, what's their selling point at this point for PRP?
PRP,
Just because they have to still
it
sell
just
it?
depends on the lack of education from
Oh, okay, gotcha.
doctors, I guess.
No,
They
not our
haven't read
listeners. We are
Myers research.
debunking this. We are debunking this
Yeah,
today with Dr. Estrin.
PRP.
That I'm taking this. I'm taking this to my office on Monday and being like, guys, just chuck it. Well, we'll use it. We'll use it till we're done. But
Well,
but we don't need to buy those test tubes because there are different tubes. I mean, I don't think people realize this, but you got a centrifuge that you need to buy, and then you got all the phlebotomy stuff, and then the tubes. And they're disposable afterwards. But we have the yellow and the red, and we have the blue. So we actually have all three. But I guess we don't need the yellow anymore. We'll just stick to blue and red.
so PRP still stuck around because it stayed in liquid form. So you could use it as an injectable where PRF was solid. But now that we've figured out the protocols, the centrifugation time, and the plastic tubes, you can produce PRF in liquid form. So now there's absolutely no reason for PRP.
Hence LPRF,
Yeah.
liquid PRF. Gotcha. And it's funny, I've realized that too. It's like when we're trying to create what's called sticky bone, and I've mentioned sticky bone on this podcast before, but essentially when you use blood concentrate materials, which Nathan's about to describe to us, it will create this like solidified, it's more like putty. But the texture of the bone graft changes. You can pick it up and it's got better handling properties at that point. I've always felt like when I used PRP alone, sometimes I wouldn't get exactly what I was looking for, and I was like, "Why is it still runny?" But then I'd pour a little bit of the latent the LPRF fluid in there, and then it would slowly start to coagulate, and then I'm like, "Oh, okay, now we got it." So that was it. We just needed the LPRF.
I honestly can't imagine bone grafting without PRF. Every time I do, it's just coming apart. It feels like a mess. And I'm just like, how did I ever work like this before?
My first ever language was Turkish growing up.
Okay, cool.
And then I learned Farsi, then I learned English. But it's funny because I feel like I cannot, now that I speak English so well, to trying to go back and learn another language is difficult. And it's this scenario where it's like I've learned to use PRF in my bone grafts. As soon as I go back, I feel like I'm a little kid again. Like I'm not even able to do a bone graft again without the handling properties of PRF.
Oh, it makes everything easier, especially in the lateral window sinuses.
The blood is drawn. It's put into you are choosing. Are you always choosing the blue now? Are you going for LPRF most of the time, or are you still sometimes using the?
I'm getting usually two reds and two blues. Standard procedure. The blues for flexibility. Um, the reds for the solid PRF. But actually, solid PRF is the workhorse of my practice. If I had to pick one of the two to use, I would use solid PRF. This is a concept that I feel like a lot of people miss out on PRF. Why is solid PRF the workhorse of my practice? why is it so advantageous to have a solid fibrin mesh? And that's because of the concept of extended release. So the growth factor, the half-life of a growth factor is minutes. So if you just squirt PRF all over the place, unless it stayed and coagulated, you're getting about 6 to 12 minutes of working time for these growth factors to bind to the cell wall and either differentiate or proliferate, and that's it. But if you have a piece of solid PRF that will resorb over the course of 2 weeks, it's going to release growth factors as it resorbs. So you get that 6 to 12 minutes, 6 to 12 minutes, 6 to 12 minutes over and over again. So solid PRF is a huge game changer, especially you can appreciate how accelerated the wound healing is if you just throw it in an extraction socket or you put it on the palate after harvesting for an FGG, because it heals by secondary intention. So you can really see how fast the healing is. When people say, PRF doesn't work as much, it really just it comes down to their technique. Are they using PRP? Are they using solid PRF? Are they just sort of liquid all over the place?
Yeah, I mean, I'm really gonna question their knowledge of blood concentrate if they're like, yeah, use PRP.
Yeah,
I'm
if
gonna
they use
question that.
PRP, then
But but okay,
Just
so
kidding.
I use a lot of solid PRF. So you're saying by it being more of a solidification, it's actually trapping or slowly slowing down that? Is it slowing it down or just keeping it from being access to breakdown?
Essentially, it's trapped in its fibrin clot, so it's not releasing its contents to be able to use. So yeah, it does slow down. It's the same. To a good analogy is like watering a plant. If I take a bucket of water and I dump it on a plant, I'm not doing as good for that plant as if I watered it a little bit at a time every day. This concept of extended releases is common in nature, for drip by drip irrigation to extended release pharmaceuticals, and that's really the secret of success with PRF.
I'm gonna like take us down the track of like an extraction socket, okay, for like treatment, just to help guide us. So we've gotten 2 vials of blood, or let's say 4 vials of blood, 2 solid PRFs, 2 liquid PRFs. We are now putting it in a centrifuge. Now, a lot of the centrifuges, like I know the one you guys sell, it is like presets are set
And
pretty much, or you guys.
disclaimer, that's BioPureF is Dr. Myron's company. I have nothing to
Okay,
do with
gotcha,
BioPureF. It's been great
gotcha,
to work with them and do courses with them, but I've got no affiliation with
gotcha.
that.
So I'm saying, are there presets on the machine, or do you have to like know where to turn the knob?
There's not you can put the presets in, okay, and actually he sends out a free textbook with every centrifuge so that people can read and learn the protocols. And there's different protocols for solid PRF, liquid PRF, and concentrated PRF, which is just spun down at a fast rate, so you get a small area at the Buffy code zone that's highly concentrated. But I just use the protocols for solid PRF because, to me, like I said, solid PRF is the workhorse. It's the most important type. So I want to optimize the protocols for solid PRF.
Like for ours, for example, I mean, it's pretty much solid PRF like most of the time. So that one centrifuge is almost like it's just set. It's just set. So like the assistants know they put it in, it's like close on go. And then they're pretty quick to, so how do you handle it after it's centrifuges? And how, typically, I mean, I think I forget the time because I haven't actually done it myself in a while.
Immunologies for 8 minutes.
8 minutes. Okay, there you go. I hear the ding
Yeah.
sometimes, but that's it. My assistants are then handling it. So how is it handled after the centrifuge goes off?
As soon as it comes out, the glass tubes, the red top tubes, you just pop the lids right away and introduce oxygen, because oxygen will help the clot form a little bit. Okay.
What happens if you don't open it up for like, let's say you're struggling with the tooth, you forget to open up the top for like 20 minutes?
It's fine, but I just tell every assistant, blue tubes you leave covered, because the whole goal of a blue tube is we want it to stay liquid. Red tubes, you pop the lids right away to introduce oxygen, because the whole goal is to make it clot. But it's going to clot right away. Obviously patient by patient is different. So you take out this little fibrin clot and you want to cut it right below the Buffy coat zone. And when I say Buffy coat zone, I mean that intersection where the red and yellow meet. You've got your platelets up top that are yellow in color, red blood cells at the bottom, okay? And right along that line in between are white blood cells. So you want to cut a little bit of the red so that you get that zone of highest concentration.
Yeah, I'll attach a picture of that. I have that, I think everyone's seen that picture of PRFs being pulled out of a tube, like the actual solidified part, there's like the little red. You're calling that the Buffy layer?
The Buffy code zone, yeah.
Is that in correlation to Buffy the Vampire Slayer because it's blood
I
related and
never thought
vampire?
about that, but probably so.
The Buffy the Vampire Slayer is then sliced by Blade, Wesley Snipes, right at that. So your goal is to actually do you leave any red or do you eliminate all red from the PRF?
I leave a little bit of red.
Just a little
Yeah.
bit, yeah.
If I
Yeah.
got the
Yeah,
red, I
same.
know I got the good stuff.
Gotcha. Yeah. It's like you're looking for like, like if someone's out there who's sliced prosciutto, you just want to leave a little bit, just a little bit of that prosciutto in there, just a little bit of that red in there, and that's my perfect PRF. The then I mean, are you compressing them all the time?
I'll flatten them all the time, except for if I'm just gonna throw it in an extraction socket alone without any graft material. That's the only time I don't flatten it, is if I just wanted to maintain its volume.
So yeah, a lot of times there is a press unit, just for everyone to know that when you take them out of the test tube, you can put them in this like little press box, and like it uses like pressure to kind of squeeze it out, but fluid comes out of it. What's happening when we're pressing it?
When we're pressing it, we're condensing it, and fluid is going to be given out, and that's PRF exudate. So that has some growth factors in it, but it's not nearly as concentrated as PRF itself. So if you're going to choose one of the liquids to mix with your bone graft, rather than using the exudate that's in the bottom of the tray, you're going to want to use liquid PRF.
Gotcha. Gotcha.
And try that. Next time you make bone graft, if you might be doing this already, or your assistant's doing it already, but mix a little bit of the Buffy coat zone from a blue tube, liquid PRF, okay, and mix it in with your bone graft and solid PRF cut up into little pieces. And that's the best way to make sticky bone.
That's exactly what I do. Yeah, exactly. I take that. I put like what I'll do is I'll actually put the PRF in, and then I'll start cutting it up in the actual dish too.
I think they actually did a study, comparing different ways to make sticky bone, and which sticky bone is the stickiest, had the best mechanical properties, and that one was the best.
That one you just described right there is the best sticky bone, this most statistically significant sticky bone
that you could have. Yeah, exactly.
That you could have. Gotcha. Okay, awesome. I'm glad. I mean, we took the course. I think that's where it came from. Is that technique? So that's what I'm doing. So we're creating the sticky bone. I think we're using the exudate. It's not really exudate from the LPRF, the blue tube. It's still like soft and mushy. It's like a yolky feeling, and it goes in. Then we do flatten, like for an extraction socket that I do plan on grafting. I will use this sticky bone, and essentially I I just pick it up. Like I don't pick it up with I pick it up with my like hemostats or like some kind of like soft tissue pickup. Cotton pliers. I'll pick it up and I'll just put it into the socket, and then I barely compress it. It's like a light compression, and then yep. And then I will, like, if I have a clean extraction socket, I don't like to flap at all if I can help it. Especially on an upper anterior. I'm trying to like not mobilize the soft tissue at all. I will either fold up my PRF or cut it into 2 layers and then stack it on top of each other. Is there any benefit to doing that? I've been wanting to ask you that, because I know putting 1 layer is good, but like if you put 2, does it have any added benefit there? Just more delayed release kind of thing?
More delayed release, and you can only imagine the layer that's exposed to the oral cavity is going to most likely degrade faster.
Do you stack up?
I don't stack up. I'll either use a collagen membrane, or now I'm using a different type of PRF, the extended PRF membranes.
Gotcha. The advanced PRFs. Yeah. We haven't gotten into that, and I actually don't plan on getting into that this episode, but I do plan on either getting you back and then talking more about more advanced PRF techniques.
It's just the world of PRF is changing, because you can manipulate it, the PRF, once it's outside of the patient, and do some things with it, and then have a different type of PRF to work with. So it's a really exciting field.
As it stays, like, okay, this extraction socket, we've placed the sticky bone in the socket, and then we have the solid PRF layer almost acting like a membrane, but it's not really a membrane per se. Like I don't think of it as a barrier membrane when it's just solid PRF. I think I'm like adding biologics in the sense that I'm helping the wound closure. What is that benefit? Like, what is actually happening once the patient leaves with what we put in there? And I normally suture it in place. I use like a monocryl to suture it on top, and then like a little figure
She
eight.
said it's not a barrier membrane, because that's why the more advanced version of PRF, has a place. Uh, as of now, it's not a standard of care to use as a solo membrane, solid PRF. It's not superior than a collagen membrane, that we use. But by putting it on top, the added benefit is that you're going to get soft tissue closure much faster. Okay. There's also a lot of reports showing decreased pain experience when you use PRF. I'm sure you've noticed in your practice, patients come back, they say, wow, that was nothing. I was expecting way worse or even better. I had extractions done over here, and, yours hurt the least. It's been a great practice builder.
I actually practice in one setting where I use it all the time, and I practice in one setting where I don't use it as often. It's different. So I actually get a side by side comparison, and it's the swelling, bruising, all that's down. Especially on even in my big ridge augmentations, when I like open up big flaps, layer a collagen membrane, and then I'll layer it on top, and then I'll suture, then I'll like tack it down. I'll actually I'll layer the PRF, then I'll do my sling sutures to tack my membrane when I'm doing like big ridge augmentations. And a lot of those I used to be like, I used to expect the 1 week post-op, I would see their jaw like, like a golf ball, grapefruit range of swelling. When I started using PRF more consistently, I stopped seeing that as much. But I would still tell my patients, get ready for it. And then they would come back and I'm like, man, like, looks great. And they're like, I was like, how'd you do? You just had a ridge augmentation, which I will tell you is one of the most painful things I do to patients, because I have to like slice into their muscles and rip their muscles that they use every day. And they're like, man, yeah, it wasn't as bad as I thought. It was like a week of, it was tender. They're like, it's tender when I touch it. I'm like, yeah, of course it's going to be knucklehead. Don't touch it. But otherwise they're doing great. And you're right. For example, number 8, when I don't want to mobilize the soft tissue, if I can take the tooth out cleanly, put the PRF in, the soft tissue does close. I always notice it's like the tissue's diving to touch it. It's almost like I had primary closure sometimes at 2 weeks. I see that more often at 2 weeks than I do 1 week. But 2 weeks, it looks like it's about to touch. And the pain results are like, they're often in shock of
And
like,
hemostasis control. That's
oh yeah, gosh,
she was
yeah,
bleeding. Try. Do you put it where you harvest a?
all the
Yeah,
time. Yeah, on the palate. I use it a lot. On the palate. So when us periodontist take a soft tissue graft from the roof of the mouth, especially some patients, some more than others, and it depends on how deep you go. You'll induce a lot of bleeding up in there in the palate, and the PRF is a staple in how I describe how we're going to manage the roof of the mouth. And I tell them it's for the two, like when I'm drawing the blood, I'm like, heal, heal, heal. I do all that. I do that dance, and I say, hey, this is going to help keep the blood stabilized. You're not going to bleed as much if we can keep it in place. And also, it's going to speed the process of that wound healing. It's going to start closing it in quicker. And I'll tell you, sometimes I feel like I've seen it at like a week. How long is it supposed to stay there? Because I feel like I do a palatal stent too. So I feel like sometimes I see it at a week and it looks like the PRF's still there.
Yeah, that does 7 to 10 days.
Okay, gotcha. All right, good.
So,
I'm not going crazy.
no.
Yeah.
But yeah, I'd say about half the time you'll see soft tissue closure at 2 weeks, and you didn't get primary closure the day of, and you're just shocked.
Bottom line here, PRF is a super cool and relative as far as cost entry, it's relatively low. Can you be honest with some of the prices for like entering like the machine, like
All
buying
the
machine
equipment
tube?
is dollars. To get a whole package centrifuge, including the technology you need for more advanced versions of PRF, like the extended PRF, totals is 5,000. I'd say for the centrifuge itself around 3,000. These are rough prices because like I said, I'm not affiliated with BioPRF. Um, it's somewhere in that range.
Gotcha. Yeah. I've gotten it cheaper. I've got it cheaper. But yeah, 5,000, you definitely can get going and you're locked and loaded with 5,000. And there is a code for it. But I don't think insurance covers it most of the time.
No, usually not.
Yeah, usually not. So I have a nominal fee for it, but in my perio practice, we're a fee for service. It's just the nature of having it. I can tell when I've said it, they question why no one's ever done it before. And it's hot enough. People, have vampire facials, they've heard of those. hair infusions with PRF. That's been, people have heard about it. So when you bring it up that you're using it in this fashion, they tend to think, okay, you are on top of your game in the world of like biomedicine and biodentistry.
And if they haven't heard about it, you'll blow them away.
Yeah, oh, absolutely. So again, thank you, Nathan, for taking us on this introductory course to PRF. We're going to come back in another episode in the future to go deeper on advanced PRF. But if you wanted to start getting into utilizing PRF or blood concentrate materials in your office, someone's listening, what's the best resource that you can give them?
Just go to prfedu.com and just take any course that interests you. That's really the standard of care for PRF. The most modern version of PRF is going to come from PRF EDU.
Awesome. And they might actually see your beautiful face. You're beautiful. Awesome, man. Thanks again. Now, everyone, comment, like, share. We do this for the fun and love of dentistry. We do not get paid for any of this. So please help share it around. And again, thank you for getting unfiltered, Dr. Nathan Estrin.
Cool. Thank you. Thanks for having me.